So welcome everybody. Thank you very much for joining us today. Particular welcome to all of those of you who have travelled, who are visiting from beyond our university. So my name is Elaine Kinsella. I'm Assistant Dean for Research, and I'm delighted to welcome you to this very special collaborative event. So the Faculty of Education and Health Sciences is part of our Knowledge with Impact public lecture series, and also the Irish Paramedicine Education and Research Network, so the IPERN network, and the Pre-Hospital Emergency Care Council as part of their research roundtable. So it's a very exciting event, and we're delighted to be collaborating with each of these different groups. So today is a celebration of excellent and impactful research led by our UL colleagues, such as Dr. Niamh Cummins. So it's really important for us to be doing research that's deeply engaged with real-world health challenges. So without further ado, I'm delighted to introduce Dr. Niamh Cummins, who's an Associate Professor in Public Health here at UL School of Medicine. She's an Adjunct Senior Lecturer in Paramedicine at Monash University, and she's founder and chair of the IPERN network. She's also a member of national and international advisory groups and journals, and a strong advocate for participatory health research and experience-based co-design. Needs for research has influenced national paramedicine policy, updated clinical practice guidelines, and driven forward new models of care. I've known Niamh for about 5 years, and we co-founded the Emerge Peer Support Network together for early and mid-career academics here at UL. And through this network, I've seen how passionate she is as an advocate for research, system change, and patient-centered solutions. So please join me in welcoming Dr. Niamh Cummins, speaking to you today on building research capacity in paramedicine, a sustainable patient-centered solution to wicked problems in our health system. Thanks, Niamh.
Hi everyone, just trying to get that echo sorted if we can. So thank you so much. It's a pleasure to be here, and an honour and a privilege, I have to say. Thank you, Elaine, for the lovely introduction. Thanks to you. It's so wonderful to look around the room and see so many colleagues and my students, and just delighted to be here to speak to you about my research today. So I'm going to start by, I'm going to start by doing that. There we go, talking a little bit about my background. So I suppose maybe I'm a little bit of a jack of all trades. My undergraduate was in physiology, so I'm a scientist. And my master's by research was in public health here in UL in the PES department, PE sports science, and that looked at preventing osteoporosis. That was in the topic area of aging, and I looked at epidemiology and health behaviour. My PhD then was in the same field in terms of aging, but this time I moved on to secondary prevention. So looking at screening for osteoporosis, running large international clinical trials, and that research was actually commercialised and is now available for purchase in Boots and various other pharmacies. So something I'm quite proud of as well. So I'm currently an Associate Professor in Public Health. These are my NPH crew, many of them here today, so my students, 47 cohorts this year. And I also teach on paramedic studies, and I contribute to the medical program as well, the BMBS program in School of Medicine. So our research focus is obviously in public health, it's in health system strengthening, and then within that in health services improvement. So as is the broad topic area of emergency medicine, and then within that paramedicine. So I kind of fell into paramedicine a little bit, but fell in love with it. And one of my colleagues said that I maybe could be considered one of the first honorary paramedics in Ireland. That was Shane Knox, who's our first paramedic PhD in the country, actually, who graduated to the School of Medicine here. I think he said that very tongue-in-cheek, but I take it. So other areas of interest that I have as well as paramedicine are in research capacity building, networking and peer mentorship, ageing, inclusion health, particularly in relation to mental health and disabilities, and public health education and competency building, and PPI, public patient involvement, and patient advocacy. Okay, so I wear a lot of hats, probably too many hats. So I'm also an Adjunct Senior Lecturer in Paramedicine. Monash University in Australia are an absolute powerhouse in paramedic research, and very, very proud to be part of their team, led by the extremely dynamic and wonderful Kellyanne Bowles. I'm also an Associate Editor of Paramedicine, led by Paul Simpson and a wonderful team there of Associate Editors at Paramedicine. I sit on the Wales Emergency and Primary Care Research International Advisory Board, the Prime Centre. I also sit on the public health special interest group for College Paramedics. We have a meeting actually on Saturday, so looking forward to going to the UK for that. I'm founder and chair of the Irish Paramedicine Education and Research Network. Delighted to see so many of my colleagues here today from IPERN. And I also, I'm the public health lead for the Sloan Chair Research Alliance in School of Medicine. And as Elaine mentioned earlier, I'm one of the co-founders of the Emerge Network, which is a peer support network for early to mid-career academics here in UL. So I suppose the elephant in the room, or the elephant in the ambulance, is that I'm not a paramedic. And I'm living in a paramedic world and doing a lot of paramedic research. And I've thought a lot about this, and I suppose that maybe I could be considered to be an emergency medical scientist, since my background is science. I've been very lucky. I've got to fly in helicopters, drive in ambulances, both here in Ireland and internationally. I try not to be an academic in an ivory tower too much, and very much give the voices back to you as paramedics. And I really want to support you in paramedic-led research, paramedic-driven research. We'll talk a lot more about that later on. But I suppose that is probably enough about me for now. I'm going to give you a rapid fun history of Irish paramedicine. So I mentioned in my overview of this lecture that paramedicine was the newest profession or healthcare profession in Ireland. And this was looking at some medicine, nursing, even looking at the allied health professions when CORU was founded. PHECC is relatively young, really. It's only 25 years old this year, celebrating 25th birthday. So that's the Irish Emergency Care Council, who are a statutory regulator. So they maintain the register of paramedics. The National Ambulance Service was founded from the Regional Ambulance Service in 2005. There was actually a national research strategy published in 2008, one of the first internationally, which was really, I suppose, progressive for Ireland at the time. And we had our first bachelor programme then in 2016 here in the University of Limerick, and colleagues here from Paramedic Studies today. And then IPERN was founded in 2021, and we had our research strategy then just published last year. So looking at some early evidence-based practice in paramedicine, research in the pre-hospital field is hard. Research in every field is hard, but particularly hard on the side of the road, in the lashing rain, at 3 in the morning, in the dark. Yeah, I think you'd all probably agree with that. So it makes it a little bit trickier. So, but we have developed some of the early research in CPR. You can see here the barrel method. Not particularly sure I'd be a fan of trying that, but obviously we progressed on from that sort of resuscitation methods to what we have much more advanced today. So evidence-based EMS in the noughties then, I thought this was an interesting, and this was sort of a seminal document and paper in the United States. It was called Emergency Services at the Crossroads. And what they found was that only 5% of EMS interventions at the time were supported by high quality research. 50% had limited or no. It actually said no research behind the interventions that were being done. So fairly shocking, and they concluded that EMS services were operating blindly, and there was an almost total lack of evidence. So quite damning, really. And now, thankfully, it's almost 20 years ago. We have progressed a lot since then. But just to note, I suppose, in terms of the international scene, that was only 6 years after the foundation of PHECC. So, you know, Irish paramedicine has really caught up very rapidly. Waddell's Triad, an example of, I suppose, research myths or fallacies, maybe. Anyone in the room tell me what Waddell's Triad is? Chris?
Nonsense.
It's nonsense. Okay. What is it? Did you teach it?
Oh, no, I got taught it about
You got taught it.
25 years back in the last century.
And do you tell me what it is?
It's the pattern of injuries in paediatric pedestrian versus vehicle. So
yeah, perfect.
The side, the head, and the contralateral head injury when you fall.
Exactly. Yeah. So a pattern of injuries in paediatric victims of motor vehicle collisions, or RTCs, road traffic collisions, as we say here in Ireland. So Waddell's Triad, taught in every course, in every book, every textbook for a long, long time. What's the evidence? This paper here, occult injuries in pedestrian accidents. So it's quite small, so you're not going to be able to see it, but you might just even know from the table. Quite a small sample size, yeah? 13 actually, 13 patients. Female, male, female. Okay, nice gender range there. You can't see it, but they're all adult patients. There's not a single pediatric patient in that. And that became the dogma for years. It was taught like that in every course, every paramedic textbook for years and years. Waddell's triad, based on nonsense, as Chris said. So really, an indication that we needed to change and base what we're doing on the evidence. So this was a nice quote I taught from Gregory in 2011. All pre-hospital practitioners should participate in the task of establishing a body of knowledge that relates specifically to pre-hospital care. Because what we're doing a lot of the time is we're using this heirloom knowledge, passed down from generation to generation, maybe not particularly without evidence, and also taking interventions that worked in the emergency medicine setting and applying them in the out-of-hospital setting. And that doesn't necessarily always work. So thankful that I've been involved in some research which contributed to changing practice. It was knowledge translation or knowledge with impact. And the first one to mention here is some work that we did on extrication and spine injury. So this was an observation by a colleague of mine, Mark Dixon. Mark's a fabulous colleague. He founded the paramedic degree program here in UL, and many of you will know Mark. And Mark and I were chatting one day, and he was saying to me, there's no evidence for the Kendrick extrication device. He said, no evidence for it. And I was like, okay, I'll have a little look, Mark was the education lead, I was the research lead. So I went on PubMed and found 2 papers for the KED, which related to lung function. And we were using the KED every day to extricate patients from road traffic collisions. And there's just zero evidence for it anywhere internationally. And Mark was like, how could we do this? And I was, as I mentioned earlier, I'd done my master's in a PE sports science department. And I was like, we can actually use biomechanics. We can take the cameras that they normally use. And I see one of my colleagues from X down here. I'll be very careful what I say here. But take those cameras they normally use to analyse a golf swing or a rugby kick and use them, apply them in the pre-hospital fields and apply them to how we remove patients from road traffic collisions. So put them on paramedics, put them on the firefighters, put them on the patients. And that's what we did. And we did a small study, initially a proof of concept study. We took, the results were, we were expected, but also unexpected. So we found that there was far more motion in any of the ways where we were trying to restrict motion. So by spine, collaring and boarding, any of those, any way we took the patient out the back, out the side, always more motion than the patient self-extrication. Now this is assuming obviously that the clinical conditions allow self-extrication. But so we took this and we presented it in Florida at the NEMSP conference, and we got not just 1, but 2 standing ovations. I've never seen that before at a conference because everyone thought the exact same thing. We've been doing this for years and there's no evidence for it, and we're possibly harming patients. So we went on from that. We got some international funding from the FALC Foundation. We powered up our study. My colleague Elish Hannigan from School of Medicine came in, did her wonderful statistics. My colleague, my other colleague I should mention is Dr. Joseph O'Halloran, and now in the University of Portsmouth, who did all of the fantastic biomechanical analysis for us. And we confirmed in a larger powered up study that actually, yes, we are, I suppose we're extricating patients, not the right way, or, we don't need to be always calling and boarding, because that immediately sets in chain. It increases response times on scene. It means immediately as soon as they go to the emergency department, a different pathway. So we managed to change practice on this. There was a roundtable held by PHECC. There was a position paper, and it took some time. And we collaborated with all the key stakeholders, everyone from paramedics, like I said, in field, to surgeons, spine surgeons. But ultimately, the CPG was changed. So that was something that impacts care every day. Every time an ambulance responds to an RTC, the paramedic now has the clinical autonomy that they can make that decision and that they don't have to collar on board every single patient. Another fairly meaningful research study that I was involved in, I was invited by the National Ambulance Service to do a pilot evaluation of the emergency and medical service. So this was due to emergency department reconfiguration, which I'm going to talk a little bit about later. And at the time, the ED in Roscommon Commoners closed down. So political power led to the foundation of a pilot emergency medical service. So it was just funded for 1 year. And we had to prove that we could, that there was feasibility in this and that it was worth maintaining. So, so it was a collaboration between National Ambulance Service and the Emergency Medical Service based in Custer Barracks in Athlone. And I analysed a year of data prospectively as we went through, and we showed that there was a clinical benefit to this. And the main one, obviously, quicker response times, particularly for rural areas, and for STEMI patients was a really big one, that we were now getting patients into the cath labs and getting them thrombolysis in time, and for stroke patients and STEMI patients. So really, really important clinical outcomes there. And to this day, the Emergency Medical Service is extremely active. There's now 2 helicopters, and actually they're looking at now potentially changing the crewing model. So that's quite political and hot potato at the moment, but we know we'll be guided by the evidence, as we always are in terms of making those decisions. So paramedicine and public health, I just want to talk a little bit about those overlaps. So paramedicine sits right there in the centre between public health, public safety, healthcare and emergency management. So everything from disaster response to care in the community. So WHO describes emergency medicine, I'm using emergency medicine broadly here, as secondary disease prevention, and then also can be used as a tool for primary prevention. And it's an integrated system, and I would say the same about paramedicine. So the CDC it termed it more than a ride to the hospital. So I think that was quite a blanket statement, but we can see here again where those overlaps are between injury prevention right up to disaster operations. So it's a mobile health service. This figure is one that is it's in one of the public health textbooks, and it's often seen in used in a lot of presentations by public health academics, and it always gets my goat. Because what it shows is that paramedics are down here downstream, as we say in public, and pulling people out of the river, whereas I would actually argue that actually paramedics play a role in upstream as well and can help prevent people falling in the river in the first place. So I corrected this for them. There we go. So now we got our helicopter and our ambulance and our paramedics up there at the broken bridge, and the arrow in terms of that they can act in both capacities, upstream and downstream. So I mentioned that I work with College Paramedics Public Health Special Interest Group, and for Allied Health Professionals Day last year, worked on this infographic which demonstrated all of the different roles that paramedics play across all of the public health domains. So everything from health protection, working in immunisation programmes. We saw that during COVID-19, paramedics in Ireland doing vaccinations, doing the testing, screening, population healthcare. Paramedics bring healthcare to the patient, reducing avoidable hospital admissions, wider determinants of health determinants, and then health improvement as well. Paramedics take a holistic approach. There's also that making every contact counts, a MEC approach as well. So, and then champagning, I suppose, public awareness campaigns like your FAST campaign. We're going to hear more about stroke later on today, and CPR awareness and so on. So paramedics work across all of those domains. And this is a really nice discussion paper, which I was looking to contribute to as well, published by Public Health England a couple of years ago, just after COVID-19, and really showed the acknowledgement that paramedicine is now really a part of the public health system. So again, I suppose all of my students here will be very familiar with this, the rainbow model, an example of a socio-ecological model. And this was a nice paper that was published, and it's actually a Canadian paper, but it states that paramedics have untapped potential to address social determinants of health in Canada. And I would like to change that to Ireland, because I think that absolutely there's a huge capacity there to address the social determinants of health. So, wicked problems. I mentioned those in my title. Would anyone be brave enough to shout out and tell me what a wicked problem is? Any of my students, don't make me pick on you. Isn't that always what I say? Anyone in the room? A wicked problem? Anyone? Okay, I'll tell you. The wicked problems represented by the knot. So problems that are difficult to untangle. Problems that as soon as you start to solve them, the nature of the problem changes and makes it more difficult to solve. Classic example is ED reconfiguration here in Ireland. Here in the Midwest, we know that UHL has, one of the biggest issues with ED crowding. Yes, the closure of the smaller units, Isosenenis, Johns, and Nina. At the time, the argument was that we were looking for centres of excellence. There was issues around, I suppose, competencies for staff at the smaller EDs. And I'm not saying that it was wrong, reconfiguration. I'm not absolutely not saying that at all. But what wasn't done at the time was putting the capacity in place at the larger academic centres of excellence. And then we see now what we're seeing, the impacts of that in terms of the overcrowding crisis in UHL and in other hospitals across the country. So wicked problems are issues that feature high levels of complexity, uncertainty and divergence. So it's characterised by those three factors. I particularly like this quote here by Horace Whitley, who coined the phrase actually. So he was a professor of, I think, health design. And he said, use the word confusing a lot. And I like that because wicked problems do tend to be confusing. We can play wicked problem bingo. You're all very shy today, but maybe someone will have a guess. What's a wicked problem globally? Lisa, I know you're going to give me one. One that you're very familiar with. Yeah, climate change. Yeah. Thanks, Lisa. Anyone else? Have a stand?
Donald Trump.
Donald Trump. I won't argue, but he's not on my slide.
Say. Genocide.
Genocide, yes, absolutely. War and conflict is one, but I don't, not one I have on my slide, but it is, Chris, for sure. Yeah. Anyone else?
Violence.
Antimicrobial resistance, yeah, well done. And there was another one shouted?
Violence.
Migrants, yeah. Energy crisis. Food insecurity, all related to migrants and depopulation. What one's that? Aging and depopulation, demographic transition. Anyone know what that one is? Loss of biodiversity. So they're all linked, I suppose. And then antimicrobial resistance, all wicked problems that are really difficult for us to solve. What about in our Irish health system? What are our wicked problems specifically? So in terms of ageing, so these are all taken from the State of Human Health in the EU and the Irish edition, which was published in 2023, the most recent version published. So in terms of ageing, our life expectancy is higher than the EU average. So we have an ageing population and we need to manage their health. Hospital capacity. Still, even though we have been increasing capacity, we still have a deficit of over 900 hospital beds, and most of those are in the acute setting. Hence, emergency department crowding. Workforce shortages. 10% of doctor posts in Ireland are unfilled. I'm going to say that again. 10% of doctor posts in Ireland are unfilled. That's not temporarily. I took those out. There's actually, I think it's 79%, and then there's some that are part-time staff or temporarily staffed, but there's 10% that are unfilled. And biggest deficits are in general practice, particularly in rural areas. As of this year, 2025, we are short 1,000 GPs nationally. Huge issue. Mental health, it's estimated that 1 million Irish people have a mental health disorder. Health behaviour. So behavioural risk factors contribute to more than a third of deaths in Ireland. So that's your smoking, your alcohol, physical activity, lack of physical activity, your obesity, and so on. And then inequalities. So inequalities, they relate to our tier design of our Irish healthcare system. We don't have universal healthcare, and that is a big factor as well. So this is Dr. William Haddon Jr., actually. So he's known as the father of injury prevention. So an American physician, a graduate of Harvard Medical School and Harvard Public Health Department. And he stated that every patient who presents to an emergency department is a failure of the public health system. He was also the first administrator in 1966 of the National Highway System, so our version of the Road Safety Authority. So it was a huge role at the time, and he did some really wonderful work. This is Haddon's matrix. So again, all of my students down here will love to hear about conceptual models and frameworks. So this is a phase factor matrix of 9 cells. So on your rows, across the rows on the table, you have your phases, pre-event, in this case, event and post-event. And then on your columns, then you have your topics or your factors. So I suppose in public health, again, we would be talking about primary, secondary and tertiary prevention of disease or injury. Again, we're coming back to our road traffic collisions. We're going to talk again about those in a minute. So just a little laugh for you. Conceptual model frameworks. My students are always hearing them, like I said. Frameworks are everywhere. When you find that perfect framework, and then actually, no, it doesn't really work for you. And one does not simply implement a framework. Neither does one implement a research strategy. It's not that easy. I was going to talk a little bit about it again later on. Okay, so overcrowding in DEDs, I've already mentioned the trolley crisis, also known as colloquially. This graphic down in the bottom left for you guys was actually from pre-COVID, and you can see there the peaks and troughs. And actually, way back, I think it was early 2000s, when Mary Harney was the Minister for Health, she called it a national crisis when I think there was 100 patients on trolleys nationally. Now we've quite regularly 100 patients on projects in every emergency department around the country. So it is a real crisis. I mentioned UHL being one of the most significant where that's an issue. This is from yesterday morning. I wasn't organised enough to have it done for this morning. But it's from yesterday morning, the national summary from the HD Urgent and Emergency Care Reports. They count trolleys every morning at 8 a.m. The national summary at 8 a.m. yesterday, there was 111 patients in trolleys in emergency departments. This is May. We're not in flu season. This is May, and there's 111 around the country. There's another 58 in wards, 169 in total. Waiting more than 24 hours, 31 patients. And then if you look down there, delayed transfers of care as of midnight, 390. So quite significant. The one positive on that slide is that there's no one over 75 years. That's KPI. And that's one of our real missions that we've tried to reduce is older adults waiting on trolleys for longer than 24 hours. So lots of challenges there. And I think research is the solution. So I've done some work on ED crowding led by my colleague, Professor Rose Galvin. And together we did this research study which looked at, it was called the Better Data, Better Planning study. And we looked at the factors that influence ED crowding. And we looked at, from a patient perspective, we did interviews, we did surveys with patients. We also looked at the clinical data. And we had 4 publications in that study. The first one looked at the impact of COVID-19, because of course we had spent ages setting up this trial, and then of course COVID-19 came along. And so we looked at a pre and post COVID-19 and how COVID-19 impacted in emergency departments, UHL. And then secondly, then we looked at the factors influencing patient attendance. Not always what you would think. In many cases, patients acknowledged they knew it wasn't an emergency when they were attending the emergency department, but there was nowhere else to go. And that's what it really demonstrated, that there's a gap in urgent care. And so lots of really interesting findings on the BDBP study. Another really nice piece that we did on it was we looked at clinician consensus, because there's a lot of talk, I suppose, of inappropriate presentations to the emergency department and indeed inappropriate calls to the ambulance service. I'm not saying that's not an issue, but is it as much of an issue as we think? Also, what we looked at was could GPs, who often refer patients into emergency departments, and emergency medical consultants agree on what was an inappropriate presentation? Turns out they couldn't. So what one of my colleagues actually said, emergency medicine consultant, I'm sure most of you know, Professor Conor Deasy, Conor was I said, GPs are from Mars and emergency medicine consultants are from Venus, was what he said when I saw the data. So it was a really clear cut that actually, how can we expect patients to know what's inappropriate if the doctors themselves don't know what's inappropriate? So we also then looked at this across healthcare professionals in the emergency department. So we looked at the different levels of doctors. So, you know, your specialist registrar, your junior doctors just out of college, and emergency medicine consultants and emergency nursing and paramedics. And we looked at it across. And again, very little agreement. And we're also doing it for paramedics as well. Actually, that paper is just about to be submitted. So very interesting findings there on ED crowding, and all this is adding to that body of knowledge, because there is very, very little, even though it's such a significant problem in Ireland, there's very little done on it. So some of the other work that I do relates to capacity building in paramedicine. So one of my babies is IPERN, Irish Paramedicine Education and Research Network, founded with some wonderful colleagues who are equally as passionate about research as I am. And we set out to build research capacity using a participatory approach. So we want to develop knowledge and expertise and build research skills and support paramedics to bridge that theory practice gap. So we try to meet, we have meetings or online usually, but we're moving into the more in-person sphere as well, every 2 months. Fabulous committee, we have a number of special interest groups, and we're interdisciplinary, and that's really key. So the majority are paramedics, but others are non-clinical like myself. We have pharmacists, we have nurses, we have doctors. So it's really fabulous, and everyone is always very welcome. And it's we very much focus on, I suppose, you know, first-time presenters, that we're a welcoming space for anyone who's interested in getting started in research. There is the fabulous team. Some of them are here today. So wonderful to have them here. And I won't name them all out now, but all fabulous colleagues, and delighted we kind of found our tribe, I think, in terms of Irish paramedicine research. We like to think that we're interdisciplinary, participatory, engaging, resourceful and nurturing. That's our IPERN. And this is some of the crew here at the PHECC conference last year. I also want to mention myself in terms of capacity building my PhD students. Actually, one of them no longer a PhD student, Dr. Luna Cronin. Some of you locally here might know Luna. She was an emergency department nurse here in UHL. I went on to do her PhD and just recently got her PhD, passed her Viva. So delighted for Luna. Her research was looking at personalised healthcare, and she was looking at 3D printing as a mechanism for personalised healthcare. So a little bit different paramedicine, but I definitely think there are scope for 3D printing within pre-hospital field, and that's something I might look at down the line. Eamon Byrne, then Eamon is here in the room, and I'm delighted that Eamon is not presenting on our panel this afternoon. So Eamon is actually enrolled in Trinity College with my fabulous colleagues, Louise and Brian up there, and he is looking at the pathway to the emergency department and looking at how paramedics respond to patients who self-harm and with suicidal ideation. And Eamon is recruiting at present. If anyone is interested in participating in his survey, I'm very much welcome. He's just doing some really wonderful work. It's such a difficult space, and there's very little research done in the field. So we really would like to support paramedics in that space, and obviously patients and families as well, to have better outcomes as well. And then lastly, Yousef Al-Ratabi, who's enrolled in Monash University, and Yousef is actually looking at pre-hospital research and developing a pre-hospital strategy and a research agenda in Saudi Arabia. So he's following actually the model that we did here for Ireland, so that's the connection there again. So co-supervising with Professor Kellyanne Bowles there in Monash. So paramedic PhD is a register of paramedics. So I'm just trying to get to here now, research capacity in paramedicine. So it's a database of the registrar of paramedics who've done PhD. Ireland doesn't feature there on that one. We do have a few, and actually we have Lisa one in the room. My colleague Dr. Chris O'Connor is here, and but we have, I think we've 4 or 5 now. We've in the country, and we have another couple studying at the moment. So it's fantastic, it's capacity building, but equally, I think our physio department here would graduate 4 or 5 PhD students in the space of a couple of months. So we really need to work on. I'm not saying that everyone has to have a PhD by no means, but it is great to be able to drive and lead that paramedic research. We need these people who are really experienced and have those skills and those methodologies to drive it on. Another issue, I suppose, in terms of paramedic research, this is a study done by Olafsson et al. That's Alex, who's a colleague actually in Monash, and he did a study looking at all paramedic research internationally and who it was led by. And it's mostly led by doctors, not surprisingly. But thankfully that's starting to change. And indeed, people like myself, non-clinical, and again, we prefer to see paramedics leading it and us to be there in support roles. And this is very similar to what we actually saw in Ireland when we did the same research. Again, in terms of the papers published, 50% of papers medical doctors, and in terms of the top 10 cited papers internationally, only one of them was bioparamedics. So we really want to see paramedics, I suppose, driving forward their own research for their own profession. So this led us, I suppose, to develop a national research strategy for paramedics in Ireland. The Pre-Hospital Care Council IPERN-PHECC showed great vision, I think, in funding this research and putting forward this plan in place for research in Ireland. So we developed this plan. We looked at, I suppose, the first thing we did was looking back to go forward. So we looked at the research history. So looking at, we did a scoping review of all paramedic research published in Ireland since the foundation of IPERN-PHECC in 2000. We then did a priority setting exercise, the Delphi it's called. And we did a modified Delphi exercise to establish what are the research priorities for Irish paramedicine going forward. We then did some focus groups looking at the barriers and facilitators to that work. That actually piece of research took place here in this room, and I think some people here in the room actually contributed to that. So fantastic to have you back here today to hear about some of the findings. We then did some stakeholder interviews, so one-on-one stakeholder interviews to hear more about and get more context to our findings. And then the future is our implementation piece and how we're going to integrate these findings longer term. And what the last thing we wanted is that, you know, the research strategy ends up gathering dust on the shelf. We wanted to, you know, actually be impactful. So the research team, fabulous research team. I cannot say how wonderful they were to work with, and just, you know, a joy really, and so much fun we had in doing this research strategy together as well. Across from an international team from Australia, UK, Canada, and colleagues here in Ireland, and really fabulous team, and many of them here in the room today as well. So great to see them here, and that's pictured at the PHECC conference last year, I think, possibly the year before, but last year, I think. So So just to look at what we did, I suppose. An overview of the research. We did the review I mentioned. We identified the research priorities. We then did a member check. So we went back and checked in with our participants in the research who participated in the Delphi and kind of asked them a little bit more context in that, some small focus groups. Then we did some larger focus groups looking at the barriers and facilitators specifically. And finally, we did stakeholder input. So that was with non-paramedic stakeholders. So what do I mean by non-paramedic stakeholders? So I mean your colleagues in emergency medicine, nursing, maybe non-clinical. We spoke to the voluntaries. We spoke to senior management in the different ambulance services. So we threw that net wide. We spoke to a lot of different people that have that impact on policy, I suppose, as well. Might not be specifically work in paramedicine, but who work broadly on policy in health services. So let's go from the review findings. So it's a little bit small, so apologies for that. But what you'll see here is there's one bar that's really wide, one topic area that there's loads of research done in. You can probably have a guess. Anyone? RESUF. Yeah, RESUF. So cardiac arrest research. We do a lot of that, and that's the same internationally. And there's nothing wrong with that. It's, you know, obviously it's one that's a very serious outcome, but also maybe it would be nice if we diversified a little bit more as well. So the second one then, the graph up there is looking at the types of research that we do. And we primarily do a lot of quantitative research here in Ireland. Starting to see more mixed methods, starting to see a bit more qual, but traditionally it was always very quant. And then the third one down there then is looking at number of research outputs per author. And you can see that the huge majority just had one research output. And to me, that's very telling and very disappointing as well, actually, because what that says is that a lot of paramedics are doing research for a qualification and then maybe not getting supported the way they do and have a bad research experience and then not coming back to do more research. And to me, that's really sad because I'd love to see everyone, you know, bitten by the bug and doing more research. And that's not the case at the moment. So hopefully we can try and change that. Again, absolutely not saying every paramedic has to be a researcher, but every paramedic I do think should have an understanding of research and how it impacts on their practice. So our Delphi findings then, so these were what our future research priorities. So we did actually 4 different aspects. We did priorities, processes, resources, and outcomes. So our research priorities, actually interestingly, were staff wellbeing, a huge one. Even pre-existing the COVID-19 paramedic, it's a tough job. And if you can't maintain the workforce, then obviously then that's going to impact on patient care ultimately. So we really need to mind our paramedics. And so staff wellbeing came up as really strongly, education and professionalism, and then what you'd expect, your acute medical condition. So that is your strokes, your cardiac arrest, and so on. Our key processes, education, again, came up as the first one. So when we did our Delphi, by the way, we had about, I think initially we had about 400 paramedics in the expression of interest. So we went down to our rounds. So we go through our rounds of our Delphi. So 70% was set as our a priority consensus. Once the topic reached 70%, then it moved on to the next round. As in, yes, we agree this is the priority. That's kind of how the Delphis work. So education really strong, education again really strong in the resources section, along with leadership and staffing coming up again. And then in the outcomes piece, practitioner well-being again coming up really strongly, staff satisfaction, evidence-based practice. People want evidence-based practice, people want more research. Practitioner development, again, we're seeing that more again on education focus, and then patient outcomes obviously are really important as well as paramedics want to improve. So when we broke those down, then we kind of looked at maybe what was within those categories, within say acute medical conditions, what you expect, you know, cardiac arrest, so on, sepsis, COVID-19, I think came in there, vaccination side effects came in. Within staff wellbeing, were things like seeing things like CISM, critical illness and stress management, musculoskeletal injuries, quite common in paramedics, peer support, all these things really key. Within education and professionalism, we're talking about things like professional registration, previous education, bridging courses, transition, simulation learning, becoming really, really big and really important. So those are kind of what we saw within our priorities. We then did our focus group study where we kind of teased that out a little bit more. And we broke those down then into 2 themes. So we saw challenges within the research landscape and then opportunities where we could build this research landscape. So I just, when I was doing that analysis, I kind of saw that things were broken down into individual barriers and then system barriers. And within the individual barriers, we saw things like experience and skills. Like, I remember one of the quotes, somebody was like, I would be terrified to go back and do research. And I was like really shocked by the use of the word terrified, you know. So just a little bit of fear there around research, you know. And I always say, I can do research, anyone can do research. I mean, the first time, you know, you intubated someone, it was hard. The first time you extricated somebody from a car, it was hard. It's just like any other skill. The more you do it, the easier it gets, you know. So we see well-being coming up again, time being a really key. System barriers and operational barriers, educational, professional, research infrastructure, as in a lack of research infrastructure being a barrier. And then on the other side, we saw in terms of system facilitators, a positive research infrastructure is obviously a facilitator. Collaboration was a big facilitator. And then in terms of the individuals we're seeing, and really what we're seeing now the last couple of years is professional identity and kind of evolving roles, because we're starting to see we're moving towards the specialist paramedics. We're seeing different roles, community paramedics, and that's within the system. So so that's kind of, I suppose, boosting that as well. And protected time was a big one, a really, really big one. And we would love to have seen protected time sort of within the research strategy, but obviously it's a really difficult one for services to commit to that when they're under so much pressure. I do have some sample quotes. In terms of well-being, one quote that really struck me from one of our paramedics was that there's a vacuum of wellness. I thought that was a really, really difficult thing to hear, and not surprising, but still really telling. In terms of operational barrier, we're struggling to keep our heads above water. Research is the last thing on our minds. I think a lot of you in the room will probably empathise with that. And then protected learning time. That's where everything comes together: education, professionalism, well-being, research, all of that coming together when we talk about protected learning time. And then dissemination. So this is a really nice quote I thought from one of our paramedics. To develop and become a profession, you must have published information. You can't get published information if you don't do the work. You have to do the research. So then we moved on to our non-paramedic stakeholder interviews. They talked about how we get it done. You know, how we move to the next stage. Funding is key. They all said that. Health Research Board is one of our big funding bodies here in Ireland. We've had only a handful of paramedic research projects funded, and we would like to see that change. Learning from working with other healthcare professionals, implementation science and implementation research being really important. That the findings were useful with caution. One of our big limitations, but we had very limited input from patient groups, patient advocates. So that is something we would love to do more of in the future. Then in terms of the paramedic profession itself, that there's lots of stuff around legislation, scope of practice. For example, here in Ireland, we don't, primarily for the most part, we don't treat and refer unless you're within the specialist pathway, whereas internationally, that would be more standard. Education is key. That came across again and again, and research training needs to be supported. So those are a couple of our publications on the strategy, one or two more on the way, I think. But to me, they was not the most important. This was the most important. So myself and Pat here, who was chair of the PHECC Research Committee, launching the research strategy at the PHECC conference last year. And it was just, I think, a really important moment for Irish Paramedicine. Like I said, thanks again to PHECC for funding that research. I think really, really important vision from them. And we'd love to see it moving now to the next level. So some other knowledge with impact, I suppose, in terms of, I'm going back now to wicked problems and ageing and older adults, and emergency care of older adults is particularly, I suppose, something that's quite difficult. I mentioned earlier about how the focus on KPI of not having older adults on trolleys in the ED for longer than 24 hours. Some work I'm doing again with wonderful colleague, Professor Rose Galvin, who leads on this, is looking at screening instruments in the ED, predicting adverse outcomes. I think that actually we can screen in the pre-hospital setting and start that pathway earlier. Actually, everything, all of the components of things like the ICER score are actually there on your PCR, on your patient care report, and we're not really using them. So I think there's actually great scope there to do more. Frailty screening and multidisciplinary assessment. This is a really nice randomised clinical trial led by our colleague Aoife consultant geriatrician, and just really nice collaboration there across disciplines within the emergency department in UHL. What about pre-hospital solutions? That was one of the I suppose, key parts of my title, my talk. Pre-hospital solutions. So we all know someone care obviously is about bringing the right care to the right place at the right time. The Nasita Gurma Sapobal Amuka is putting out the blue lights in the community. So we're talking about, I suppose, there's real scope and real opportunities, I think, in terms of alternative care pathways like community paramedicine, Pathfinder, EDIT, and the APCAR. So these are research that's done by my colleagues, and I'm just going to give them a tip of the hat here because I think there's some wonderful work being done. The Pathfinder service and some of the Pathfinder team are going to present here this afternoon on a really new and wonderful intervention, which is looking at point-of-care bloods for older adults in the home. So again, preventing that trip to the emergency department. We know as soon as an older adult steps foot into an emergency department, immediately morbidity increases just by having stepped in the door. So so we really need to try, if we can prevent that, if it's avoidable, then it's wonderful. So Pathfinder's collaboration between National Ambulance Service acute hospitals puts OTs and physiotherapists into ambulances, and they go out and visit in the home and see if they can provide care on site and also transport if necessary to ED. So that's the Tala team there, and doing wonderful work all around the country and here in the Midwest as well. Pathfinder team's active. Led by one of my IPERN colleagues, Jamie, go on to one of that team actually. And Jamie is somebody who's always been a great advocate for research. One of my first researchers I supported when I started working here in UL as a emergency medical scientist, as I mentioned earlier. So Pathfinder is two of the things I mentioned earlier. It's sustainable and it's patient-centred. How do we know that? Because we've done the research. So props to my colleagues, Paul Bernard. Paul is an OT with Pathfinder, and they've looked at the safety of Pathfinder as an alternative to ED. And then also Grace, the physio with Pathfinder, Grace looked at older people want to be in their homes. And that's we hear that over and over again in terms of the research internationally and in Ireland. So older people don't want to have to go to the emergency room unless they have to. And that was one of the outcomes actually of, I mentioned the Better Data, Better Planning study earlier as well, one of our studies on ED crowding, and that was during the COVID-19 pandemic. But older adults were actually terrified then to go to the, afraid of contracting COVID-19. But really people want to be cared for in their homes, in their communities, if at all possible. Speech and EDIT, other examples, and I think one of those teams that's just started in UHL, that's been in some of the Dublin hospitals like Vincent's for a long time and been very successful there, led by Rosa. Rosa does fabulous work with older adults in the emergency care setting, and all of her team. The ABCAR team, again, has been around the country for longer, more recently in UHL. This is the Alternative Pre-Hospital Pathway Team, a hospital admissions avoidance initiative. This was where we have an emergency medicine doctor responding with a paramedic or an EMT in a mass response vehicle. So again, going to see older adults in, not just older adults, I think from that perspective, in the home. And the aim again is to reduce the number of necessary ED attendances not requiring acute hospital care. So again, the evidence for that. So this is from Andy Patton down in Cork, one of the ABCAR doctors down there, and they had non-conveyance rate of 68%. So over 2/3 not conveyed. Median age 62, a third were over 75. Average number of hospital patients treated per shift was 7, so about 1 an hour, give or take. Most common presentations were medical complaints, falls, drug and alcohol related complaints, urological and respiratory. So all the things you see day to day. Paramedics in general practice, my colleague Dr. Simone Barry is doing some great work on this, and we know that this is in place in other systems in other countries like the UK, and great potential for it again here in Ireland. And this one I personally feel has real potential. So the Specialist Paramedic Community Care Paramedic role, it's just been recently introduced into Ireland, and there was a really excellent review of international research done by actually a Monash team, and my colleague Brendan Shannon there in Monash and all the team there, and they put together this really evidence-based framework for development of community paramedicine in Ireland. I think it can be quite transformative. There's huge potential there. So looking towards the future, this is a college paramedics competency framework. There's another competency framework, excellent competency framework published recently in Canada by Dr. Alan Bash. Alan was a paramedic here in Limerick who moved to Canada and is one of the leading paramedic researchers internationally now. And Alan also developed a competency framework recently. And what I would really love to see is that of the pathways there, research and development is one of them. And we would love to see that in Ireland and the development of a research paramedic role. Some acknowledgements. So I'm very lucky to have fabulous colleagues in UL, too many to mention, but I have picked a few, always a danger. The team from the Aging Research Centre, I think this photo is of the very first ARC meeting actually, which was in 2021, I think, or maybe actually no part of that, actually pre-COVID, I think it was, the Aging Research Centre. Fabulous colleague, Professor Rose Galvin. Rose is just such support and wonderful, wonderful colleague to work with, and just such a brilliant brain for research, and just really leads on and so compassionate to older adults, and just really does fabulous work. My colleague Professor Ailey Hannigan in the medical school, another wonderful mentor and colleague, and just does really fabulous work and is just so supportive. And then my colleagues Elaine Kinsella and Jenny McMahon, who we co-founded the Emerge Network together, previously mentioned there by Elaine. Also mentioning maybe just some colleagues, external colleagues, so Mark Dixon I mentioned there, and Mark was a colleague here in paramedic studies, and Dr. Damien Ryan in the emergency department, who's also an adjunct here in School of Medicine. I'm noticing now that these are a lot of awards. It's not that we're showing off or anything, it's just that we never seem to take photos. Although this one of me and Professor Kellyanne Bowles is on top of St. King John's Castle, when she came to visit Ireland 2 years ago, and Kelly is a fabulous colleague in Monash, and Kelly is in some ways my sister from another mister, in that she is a non-paramedic working in a paramedic world. She's a sports scientist actually, and she's head of department in Monash, and just really another just wonderful mentor and real believer in the pipeline of supporting others and putting that arm down and helping others up and to come up behind you. So, and then equally, I could say the same for Professor Julia Williams, who's in the University of Hertfordshire and also leads College of Paramedics research in the UK, and then Dr. Alan Batt, who I just mentioned as well, and the most important thing you need to know about Alan is that he's from Cork. So I think that is it. Thank you so much, and if anyone has any questions, I'm happy to take them, and thank you very much.